Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect with your profession. I'm Nicole.
And I'm Leo. In today's episode, our guest is our PTA member at large, Abby Catamas. We discuss how she came to APTA Acute Care leadership, plans for advocating for PTAs in our setting,
and what reality TV shows she's now watching. Enjoy the show.
All right, welcome to another episode of Acute Conversations, the official podcast of APTA Acute Care. For today's episode, our special guest is PTA member at large, Abby Catamas. So, Abby, thank you for joining us tonight. I think one thing I want to say is that I think the first time I met you was, what was it, was it a year ago? Was it the leadership meeting?
Strategic planning last year. And
it was strategic planning over on the East Coast, over by APTA headquarters.
Yeah.
And it was a great time meeting you. And then we also hung out at CSM. So if you look at the CSM episode, you can kind of hear about Abby's story, how she became a PTA. However, I think you've got a lot more information to share with us today. So welcome.
Hi. Yeah. So PTA member at large, and really part of this becoming the PTA member at large was I got an email from the Acute Care Academy saying, hey, we actually need applicants or candidates for this role. So I don't know if anyone had been nominated or anything yet. So I was like, I'm assuming no one's been nominated. Let's just throw my name into the hat and see what happens. And at that point, when I was doing that too, I was also in this like weird limbo of, do I want to continue with PT or do I want to go on to do something else in healthcare or leave healthcare entirely?
Wow.
Because I was burnt out. I was also getting tired of people saying, like, telling me to stay in my lane, where I was like, this is my lane. Actually, I'm advocating for patients and what I think they need, whether it's equipment or I really think they need to go to rehab, and it's my job to fight for them to go to rehab, and being told by other disciplines essentially that I need to stay in my lane. But if a PT went up and said it, they would be fine with it. Wow. And so I was in this like weird standstill. I was like, hey, if I get elected to be the PTA member at large, great. I think I can maybe make some change or at least have a voice for the time being and hopefully for the better. And if not, I can still do PTA and I have different avenues that I can go if I need to. And lo and behold, now we're here and met Jim Smith, and he also said the same thing. You never know unless you put your name into the hat. And right. And even with that, he was like, you could also be nominated for other jobs, not just the ones that explicitly say PTA or other roles, which I was like, no, I had no idea. I'm fine with where I'm at. I love what I'm doing as a PTA member at large. I was like, but now I know that, like, I thought the moon was where I could land. Now I know Pluto's where I can go. But yeah, that's where I am. And I like to say I'm a loudmouth for PTAs. And
no, you don't say that. You're an advocate. That's amazing.
Advocate, absolutely.
I'm an advocate. I'm a very loud advocate.
You deserve to be heard. You don't have to be loud to be heard. You got this.
And
yeah.
I think from my personal experience and just other PTAs I've interacted with in my 5, almost 6 years of being a PTA now, I was like, wow, I'm not the only one feeling this at times or feeling that I'm just a PTA, when I was like, but we're so much more than just that.
Yeah. Abby, I'm so glad to be meeting you tonight. I think this is my favorite topic, and I am super glad that you're here, and I feel a little awestruck in this moment. And there's a lot to unpack in what you were just talking about in terms of that dynamic between PT and PTA, and even further, that dynamic of therapy to other professionals. And then even further with the level of burnout that can happen in that 3-year mark. I think that 3-4 year mark where therapists really, especially I think in the acute care side, start going, oh, this is a lot. And if they can get over that hump of what it is and how much we take on in acute care, it can be so fruitful. But realizing that you do have capacity, you do have room, you do have a voice, and not feeling like stuck in some kind of imposter syndrome error in there. So I'm glad that you doubled down. You applied for the role.
Good.
Yeah. So I guess my question would be, framed around what would you tell therapists that are in that phase in acute care where they're starting to say, can I keep doing this?
I think part of it was I had to shift my why, not entirely away from my initial why I wanted to do physical therapy, and not away from my why I wanted to do acute care. Because I think you can have multiple whys as you start going through your career. So I still love treating patients. I still love the acute care setting, working on the trauma ICU with patients who are newly diagnosed with spinal cord injuries and traumatic brain injuries. Like, I love doing all that because not only am I still advocating for them and what they need in their families, I now also get to advocate for my profession and my fellow PTA colleagues and what that should look like. And like we were talking about off the record earlier, was just like at the top of our license though. Yes. And so I shifted, having to try and shift my why was like, why do I want to do something more? I want to do something more because I'm a PTA who's burnt out, or I'm a therapist that's burnt out, but how can I get out of that? Something needs to change within our profession to avoid that. And so I just found like a different passion project essentially, but it's going to be like a forever project because I don't think it doesn't stop here. It's going to be a continuing thing. Even after I'm done being PTA member at large, when my term is up and things, like I still want to continue those things. So I think my best advice is just, you don't have to give up your initial why, but maybe try to find a different why. It's part of growth. It's part of developing in your career too. Sometimes it's shifting to maybe you have to work with a different patient population for a little bit. Mm-hmm. Maybe you find a new passion, but you take what you've done with one patient population and you adapt it and bring it to another patient population. Like there's carryover in what we do, or just simply getting involved. I think for me, getting involved with the academy was really the turning point of, I need to stay a physical therapist assistant. I need to stay in this physical therapy career. There's so much work to do here that can help change things for the better.
That's such good news just to hear that you were on the kind of right on the edge between, am I going to stay in this profession or not? And then lo and behold, was it just like a general email, or was it a specific email?
I don't know if it was like a call out email, but yeah, it was just a general, like, we're looking for candidates for the PTA member at large. And I got the email like 2 or 3 different times before I was finally like, okay.
Why not?
What I'm hearing is, don't send those emails to your junk.
No, exactly. Yeah. You have to open them because there is
open them once in a while.
I think if you open up any email especially from the Acute Care Academy too, or just like the APTA, you like, sometimes you'll be surprised what's in there for you to be like, oh. And even when I like send out my reach outs to my PTAs, like that are part of the academy, and I'm trying to do quarterly outreaches now, just so they have a name, they have a kind of a face, but they know where they can reach out to. And sometimes I get a few emails back. Sometimes I get a lot of emails back in my check-in, but I wouldn't know what's going on unless I did that.
So I'll say shout out to NOMCOM, because it's usually people that are in the NOMCOM that are sending out those emails, or whoever else within the different communities for APTA Acute Care. Thank you for sending those emails out because it reached you. And I also think it's funny that sometimes like you come across those emails, like you come across like the emails that you usually don't get to when you're trying to procrastinate and you're trying to not do like your regular work. You're like, let me just sift through emails that I haven't checked for a while. Let me go into my junk phone. You're like, oh,
I'm horrible. Wow. I hate having notifications on my phone. So I am like a frequent, like, I check my email at the same time almost every day, so I don't have notifications at the end.
I love those nuggets that you can find in the acute care emails that come out every time. I feel like the same thing. You could just get one little thing. You're getting a pulse check in what's important to us as an academy. So yeah, I'm so glad that you found that. How long is the term?
3 years. So I'm just now starting year 2. 3-year term.
Are you already thinking about like what's next?
Yes, I'm trying hard not to like think too far ahead because I really want to focus on what we can do now as like an academy for PTAs, but also wanting to get into, because we do have our strategic planning and everything coming up. So trying to think far enough ahead to what that strategic plan is going to look like for the next few years to set, because as far as I'm aware, like it would be another PTA member at large potentially coming in and taking over whatever strategic plan I helped develop with the rest of the board of directors and the other committee members and things like that. So I want to make sure it like also sets whoever, if somebody else comes in, it sets them up for success. And it's not like this big bit that they have to try and chomp off to. So that's also why I'm trying to make my presence really known among the other PTA colleagues and members, because that way, if somebody is interested, there can be a good like carryover and handoff type deal of what's to come. And it's not just like a shock of, oh, hi, this is who I am. And this is everything I'm working on. Good luck. You know what I mean?
So
Definitely.
Abby, for your first year, can you tell us about how it's been for this first year as PTA member at large? What have you been up to? What have you been working on?
A lot of it has just been trying to advocate for that advanced proficiency pathway. Really been trying to either email, like hunt down PTAs who have done it, who are in the midst of it, and try to get more information from them. I actually have tried to ask them if they would be willing to go on the podcast with you, Leo, and because we had talked about, could we get a PTA and their mentor on the podcast to talk about that process, or even just getting it so we can spotlight them like we do with the residency program, spotlight them on a social media, like, hey, this PTA's halfway through the advanced proficiency pathway, or they've completed it this year, things like that. Just, again, trying to just recognize PTAs where we can. The other part too is we've just had a lot of discussions in our board meetings where I think PTAs have been like, we've been considered with different changes and stuff that have been coming through the academy. And I think our board of directors does a great job of being like, what's the PTA's perspective? Or I've chimed in and said, hey, this is maybe going to hurt PTAs before it's going to hurt PTs because of either how much we make or what our scope is, things like that. I know the academy, I think, was trying to work on a certification or like a specialization or something along those lines. And I was the first one to be like, what about PTAs? And had to get clarification on that. And we have the advanced proficiency. This would be specifically for PTs and things like that. But I'm always in there trying to be like, but what about the PTAs? How could this benefit the PTAs? So my first year was really just getting my feet underneath me with what this role means and picking up with what Carrie had left off, because she was the outgoing PTA member at large, and trying to figure out, what does this role actually mean for me? Now that we're in year 2, I'm like, this is what I want it to be. I want PTAs to know who I am. I want them to feel comfortable coming to me, and I want to get them more involved. I want their voices to be as heard as mine. So it's not just me.
That's amazing. I feel like what I hear is you're being an amplifier. You're taking them and bringing it forward. For those listeners who maybe are popping in and are less familiar with the advanced practitioner proficiency pathway, give us an elevator speech of what that is to make sure that our listeners can be equipped.
So PTs have specializations that they can do. The advanced proficiency pathway is essentially the PTA's version of a specialization. So there's acute care, geriatrics, ortho, oncology. I think they're developing a pelvic health one that's going to come either next year or the following year. So with each academy, there's essentially going to be an advanced proficiency pathway. You have 5 years to do it. You have to do so many CEUs in those years that are specific to that APP you want to do. You have to have a mentor and a supervising therapist. You have to do so many hours of work to get that advanced proficiency pathway. And you have to have a supervising PT sign off that you're doing all those hours and sign off on your CEUs and things like that. And it's this big portfolio at the end of it. Like, I'm just starting mine, and it seems, I don't want to say it's not hard. It is, just because the CEUs are so specific to that specialization or like that proficiency pathway. But it's just big portfolio that you submit at the end, and you get like the yay or nay, and you do get recognized at CSM if you complete it.
Yeah, you get to walk, right? I think that's absolutely amazing. And I know we previously just touched on the fact that when we think about building, creating clinical pathways, even within boots on the ground job descriptions, that including pathways for physical therapy assistants that include clinical specialization, positions within our most complex care areas and populations, and then also within leadership, that we have an obligation to that we cannot ignore that assistants belong in those spaces just as much.
Absolutely. And I think, like you said, we have an obligation for that. And I think some of it comes from like how things are written. And this was actually brought up in one of my outreach emails this recently too, was so many certifications exclude PTAs. It says only for PTs, but it's a lot of times it's something that PTAs have the scope of practice for. And I think the example was the exercise for aging and elderly adults. Mm-hmm. That is well within a PTA scope, but we get excluded, like and it's, again, what Jim Smith has said, does it say PTAs can't get it, or is it just not written that PTAs can't get it? And so I think when it's not explicitly stated, just, again, culturally,
we need to raise our hand, right?
We need to ask, but also, can we put that there? Can we explicitly state that, or can we change the culture? So it's a certification. It's not a specialization. There is a difference still. I should be able to get if I work with people who have patients who have Parkinson's, why can't I go get a certification, better myself for my Parkinson's patients, and say that I'm certified to work with, like, I know what I'm doing to work with these patients. So I think Jim Smith said, does it not say it? Yep. No, but PTAs were just in school, and as soon as we jumped the gun into professions, into our profession, it's PTs get certifications and specializations, PTAs, here you are. And I do think PTAs should have the ability to get certain certifications, because we do work with all the same population.
Yeah, our patients deserve it. We need to debunk that, right? For the sake of our staff, for the sake of our assistants, and across for PT assistants and certified occupational therapy assistants that work in these spaces, and ultimately for the outcomes of our patients that demonstrate that when you have advanced training, the outcomes improve.
Yes.
So glad to hear that. I know personally, just an experience that I've had at my current work is we were able to rewrite some job descriptions in recent months and advocate for physical, occupational, and speech language pathologists to be recognized as clinical specialists when they achieve certain certifications, depending on the merit. So
right,
large portfolios, board examinations, things like that reach that 2,000 hours or
right,
mentored practice, a threshold of proof by an external body. And the question always came back to, the assistants have pathways, like these exist, and we need to encourage every level of practitioner to go to the top of their scope of practice. We want to continue to exist in these spaces in the hospital. We have an obligation to do it.
And I think where I currently work, I couldn't attend it, unfortunately, because I was working. So I was one of the weekend warriors, but we just had a traumatic brain injury course brought in. We had coworkers and colleagues get certified for traumatic brain, TBI. Working with TBIs. And that included assistants, thankfully, in that. And it's not, I always like to say, even if you get a certification and can't put the abbreviations or it's not always about the letters after your name. It's, can you put it on your resume, and can you actually put it into play to treat your patients and provide better care?
The whole point of that process is a transformation in your practice. And that's why it's robust. And a decent, robust program that has a standard will transform your practice. Sorry you couldn't go to the TBI course. You're going to have to find the next one, or do the Parkinson's or the stroke version. They're all there.
Yeah, they're out there. I feel like for every diagnosis, slowly but surely, we're getting more certifications and more courses, so that way we can better our practice and give our patients the best care.
Now, Abby, you had mentioned that you check in with a lot of PTAs just to get your kind of ears to the ground to figure out like what's going on. What are PTAs talking about? What are some of the things that PTAs are? What's the conversation like right now?
So
the tea. No,
pour it all out. The most recent one was the certifications. Like, why are PTAs excluded from certifications? But the other one right now that I was oddly surprised by was that I have PTAs being told that PTAs don't belong in the ICU.
Interesting.
Which, as someone who works on an ICU, and I started my career, it was in the height of COVID. I wasn't solely ICU all the time or anything like that, but I still went to the ICU as a new grad in the height of COVID. And even shifting from one place of work to the next, I was even asked as a new grad, how did you make sure you didn't do more harm than good as a new grad in a COVID, like in an ICU? And I'm like, it was COVID. We were all new grads. Collaboration. It was collaboration and discussion. You ask questions. We all work together as a team. But for the ICUs, and Leo, I mean, you can correct me, as both of you as PTs can correct me if I'm wrong here, but if you're in the ICU, some of your day is eval, reassessment. If there's so many medical changes happening, that who's going to see the treats that need to be seen? Your day is slammed with that. And then now if you don't have an assistant on the ICU, now you have patients who are potentially not seen for 3, 4, 5 days, even up to a week. If you're just constantly doing this, I had so many evals this day and I couldn't get to all of them. So now I have to push them to this day, but I have so many reassessments and re-evals that need to happen, or progress notes, whatever it may be. Your assistants are there to help do those treatments. At CSM during your debate, your Oxford debate.
The Oxford debate, yes. The PTs float from unit to unit. Yep, yes. That was our debate.
PTAs are the workhorse, but we're there to help do those things so PTs can focus on those higher level tasks that PTAs can't do because it's not in our scope of practice. We're there to help, not necessarily fill that gap, but we're there to make sure that the care is consistent across the board and that no one falls through the cracks in the set, and especially in the ICU where it's easy for that to happen.
Yeah, I feel pretty passionate about this topic when we talk about scope of practice. And again, that we should work to the top of our scope. And when there's something that we're not sure of, then that's a competency. Unless it is stated in your scope of practice, you will not do this.
Right.
Then we should work on a competency to bring people to that next level. And in the ICU in particular, you make a phenomenal point that I have never crossed my mind, that in COVID, none of us knew. It was new for every single one of us. So we were all there. We were learning. We were trying different things. We were hoping that previous responses to intervention were going to be replicated in this new disease process. And sometimes it was, and sometimes it wasn't, right? We were looking at something that was changing DNA.
And each person was different. Like I had patients that had SpO2 goals that were way lower than somebody else's because we figured out that's how their body responded. But that only came because as a collaborative interdisciplinary team had a conversation, whether it was like the PT, they're not pulmonologists, but sometimes pulmonologists, but PT, doctors, respiratory therapists, like OT, speech especially, because if they were intubated, like prolonged intubations, or needing like a Portex speaking valve so they can communicate with their loved ones, things like that. Like I have to still shout out the speech therapist in all of this with that speech month next week. So
yeah. And I guess in that is the ultimate lesson here is that that learning in the moment with this new thing that was happening wouldn't have happened if you weren't at the table. If physical therapists and physical therapy assistants were locked out of the ICU in that period, and I've heard of hospitals that have said, it's too dangerous, we don't want you here yet, then the learning wasn't there as quickly to say, this is how it is responding to dosage and intervention, and this is how it's not. But like you said, if you're staffing a physical therapist for evals and re-evals in your most critical care areas, and those follow-up treatments are getting secondary attention, why would we not have our assistants as a partner in increasing that dosage? Even if it's I'm doing the eval in the morning and an assistant is going back in the afternoon and giving a BID treatment.
Yeah, how great is that?
There's just so much.
That would be, I think that's everyone's dream, is that everyone gets seen every day. We can do BID.
We're rehabbing in the
therapist in the world.
Right. I know. I live in a dream world sometimes, but I think if you don't think it, if you don't envision it, then it certainly can't happen ever. But if we can talk and say, hey, this is a model that works and is safe and effective for our patients, why are we not doing it?
Exactly. And like my dream world is like every ICU is an awake and a walking ICU. That every hospital would be that if it was the perfect world. But even like to what you were saying, like the competencies. And I think that kind of goes back to what Archana and I presented on at conference, actually, about like improving PT-PTA collaboration for like bi-directional mentorship and partnership for improved patient outcomes. It all comes down to communication too. If I never communicate with my PT about what's going on or questions I may have, how is my supervising PT on that floor going to feel comfortable that I'm doing an adequate chart review or that I know what I'm doing with my patient if I never update them with how a patient's doing? Sure. But vice versa, how would I expect how would they expect me to trust them if I don't feel comfortable coming to them because they're not open?
Right.
Saying, hey, I have a question. The most recent example is I had a patient who was on step down, was evaluated, bounced back to ICU for an emergent intubation because of a COPD exacerbation. And then 24 to 48 hours later was extubated and back on step down, but they hadn't been seen by a PT since bouncing back to ICU and then coming back to step down. And I just talked to the therapist and said, hey, this is what's going on. It doesn't look like anything else has changed other than they had this hypoxic episode that required intubation. They're back on step down. Are you comfortable with me still seeing them? Or do you want to put eyes on them first before I go in? Because how our plan of cares are written, I was like, I don't think the plan of care is going to change. And I don't think the goals are necessarily going to change either based off of what has actually medically happened and what the team is saying in the chart. The PT was like, you can go in there and see them. I don't think anything's going to change rapidly or as far as the plan of care is concerned either. But if you get eyes on there and you feel like something has changed, just come get me and I'll take them from you. There was that communication and that collaboration. And that's how it is. I feel like with a lot of thankfully with a lot of the PTs I do work with is if I see that there's been a medical change, I still tell them, even though I know them well and I can take a guess at what they're going to say. But at the end of the day, they also may say, oh, I heard something in rounds based off what you're saying. I'm still going to take them from you. Or, oh, we might actually have to change their goals. So let me go ahead and take that one and you can pick up somebody else. But if we don't have that back and forth open communication and collaboration about what's going on with our patients, how is a PT comfortable in deeming me competent into seeing somebody? But how do I have that trust in going to them if they're going to look at me like I have three heads when I ask them a question?
Yeah, I feel like you're unlocking a truth here of the PT-PTA relationship in that traditionally, I feel like some people tend to think, oh, I'm going to hand this patient off to you, like it's this downgrade. Right. And in actuality, at how we actually practice in acute care now is physical therapy is maybe the owner of the consult per se of that initial touch point, but the specialist or the expert in the treatment doesn't necessarily have to be the same person. It's a lateral partnership that works both ways. And there's trust between both ways. Like you can trust that that patient came to you with a comprehensive evaluation that's been performed, just as much as you're communicating and saying when that treatment needs a change, you're building trust to the PT that you're sending it back, asking them for their input one way or another. It's two roles that are meant to be married.
This.
Yes.
And yes.
And I know
and those who can't see us, we're showing a level line here.
We're using our hands to pantomime.
Nicole and I are not allowed to be on a podcast together. We talk with our hands too much. But, and I think Archana has been such a great, friend, and I feel like taken her on as my own little mentor, especially when it comes to these bigger presentations and stuff now, because never in a million years when I started did I say 5-6 years into my career, I'm going to present at conference and plan on presenting at and hopefully presenting at conference again next year. Those were things that in my brain, I was like, that's 10-15 years into my career when I've done research and I've done this and I've done that and have all these degrees. No, I'm here doing it now. And I never want to stop doing it, which is not a problem. But Archana has been such a big mentor on it. And I'm glad she has. And she's definitely told me, and she's like, hey, we did this presentation. Let's try and figure out how we can expand and do something similar but different for maybe next year. And how do we change the dynamic? Because she also believes in that PT-PTA collaboration. But no, I think, and she had said it, she's, even though we supervise the PTAs, we are not like, you're not above or below anybody. We're supposed to work together.
Mm-hmm.
And that is the truest statement I've heard as far as our profession is concerned, especially in acute care.
Yeah.
Abby, the first time you met Archana, was that during that leadership retreat?
Yes. And I was
years ago?
working on the more than just a PTA like presentation to give to like schools.
Wow.
And she was like, she saw it and she's, this would be good for in the future. And then it just fell under the wayside for a little bit. And I don't remember how it got brought back up again. She was, would you want to do a webinar about PTAs? And I was like, I have that more than just a PTA. Well, she was done.
So shout out to Archana. So Archana Vatwani, who is I think she's the head of the education section for APTA Acute Care.
Yes.
And she's done a fantastic job in terms of how many webinars she's been putting out and finding high quality educators to put on our learning management system through APTA Acute Care. So for those of you that are out there that are interested in kind of looking some of the stuff up, again, check out our LMS because there's a lot of great information. And speaking about the LMS, Abby, you're on there, correct? Because you had that webinar. The title, again, like you had mentioned, it's more than just a PTA.
More than just a PTA. And it, just in brief synopsis, without giving it all away, is it's talking about the importance of PTAs in acute care and some of the statistics and evidence behind like the benefits of having PTAs in acute care and how that can help facilitate discharge and prevent increased length of stays. And it also talks about the Advanced Proficiency Pathway, because this last year I've tried to plug that in wherever I can because I want more PTAs to do it. It's there and it only benefits you in the long run.
That's fantastic.
But yeah, I'm trying to, there was another point I had and I lost it. Maybe it'll come back here in a little bit, but.
So what's next? What can we expect next from your presentation? What are you noodling on right now?
So it's still along the PT-PTA collaboration, but instead of towards like mentorship and partnership for improved patient outcomes. Again, I don't want to give away the title because it gives away the whole thing.
No,
but
don't give it away yet.
Further within from an education standpoint from PT and PTA schools, and how does that look like? What does that look like? And maybe touching on institutional policies don't necessarily mean state practice legalities or state practice acts.
Interesting, yeah.
So hopefully that's what
I like that.
Also, again, with Archana. So like, hopefully, fingers crossed, we'll see what the outcomes are of sending that in. But I would love to do that. And in my own brain with a CQI project in the future, whether it's just at my current place of work or maybe towards the actual acute care academy, is PTAs, like their retention rate, if they had a PTA or just in general, an assistant team lead or manager versus a therapist manager. I'm not saying we can't be managed by PTs, because I've had great managers who are PTs and love them dearly. But sometimes it's easier if you have an assistant as your manager who understands what you're going through and what your workflow looks like daily, to go to and say, hey, this is what's going on in my workflow. Can you help me? Or having just, again, that representation at a different leadership level to go to management and say, hey, this is what's going on amongst the assistants, and be that voice.
Yeah, I feel like you're exactly like, again, genius moments here of saying there's this, our assistants don't have as much longevity in our teams, or they will leave and go somewhere else. So it's hard to want to invest in assistant. These are things that like you hear that maybe happened one time, that this leader now feels like this whole subset of people might up and leave them if they invest in them. And it's no, you got to give a chance. And maybe make what you're saying is we got to back up and look at ourselves in terms of how are we organizing our structure of reporting, make sure that there's a voice in our assistant, even if you only have one on your team, that you're not drowning that out with the rest of your team. Like you have got to have a clear pathway for that assistant to have a voice to advocate for their profession, their practice, their needs, especially if you want to retain and train and get everyone up to the top of scope. I think that's a genius moment here looking at the future.
If you think at the numbers of like supervision, most states are a 2-to-1. You have 1 PT supervising 2 PTAs. And if every state and every setting is taking advantage of that, your PTAs in theory are outnumbering. They should be outnumbering the PTs in the settings. So why wouldn't you want an assistant representing that population? I'm not saying we have to supervise PTs, because I know sometimes that's the caveat, but we don't have to necessarily supervise your documentation, but we can have leadership skills.
People leaders. Yeah.
But
and our job description should be written as such so that your supervisors, your managers, your directors don't exclude this incredibly talented population of therapists that can rise up in their leadership if that's the path that they so choose or thrive in. But if you don't bake that into the job description, then you're doing a disservice to your own recruiting.
And there's some that I always get curious and just look on LinkedIn just to be like, what is out there for PTAs in leadership roles? I don't know unless I look. And there's rehab director positions out there. So if a PTA can be a rehab director, why couldn't they be a manager? Because it's one's higher than the other in some sense, and depending on how your institution's set up.
Yeah.
And a lot of skilled nursing facilities are ran by assistants.
Yes.
They sure are. Yeah. Abby, if we have listeners here that are like feeling passionate after listening to you and feeling like they want to get involved with you on any of these future projects or your current projects, how can they reach you?
They can reach me on my email, which is johnsonabby, ABBY, 96@gmail.com. Instagram, it's public, and you will see plenty of pictures of my husbands and my dogs. And I said husbands plural. I only have one husband. Let's be clear. I just caught that. I was like, I have one husband.
And shout out to your husband for helping with the tech.
Yes, he got it all situated.
Which one? Which husband?
Yeah. The one that's nerdy playing video games right now and keeping the dogs busy so I can do this, and my dogs and whatever adventures we go on. But I do repost a lot of things that the Academy posts or other little fun resources that I follow on Instagram. And that's Rose 17 Abby. So you can feel free to follow me there, message me there. If you're not an email person, I am still an old lady to some extent where I do email. So
I thought you were going to say we could write you a letter.
There we go.
Do that too. I just don't think I'm going to put my address out there for the public.
No.
Maybe to the work, maybe to your work location, your work address.
I don't know if they want that happening either. Not in a bad way. I just don't think they want to be pounded with a bunch of letters.
Nicole, I think we're at time. We've reached this point now in the podcast where we're going to do a rapid response. But real quick, before we do the rapid responses, Abby, are there any shout outs, any people that you want to kind of give a shout out to before we go into the rapid responses?
You want to give me one sec.
Other than your husband's.
Other than my husband's. No, I still Archana for just being a great mentor. Jim Smith just for being Jim Smith and always being the encourager. And after the first presentation at CSM, so you can't stop either. But I do want to shout out, if I can find it, all the PTAs who finished their Advanced Proficiency Pathway. We have Jody Casey, Emily Christian, Madison Culp, Cameron Del Rosario, sorry if I butchered your last names, Tanya Kennedy, Michelle Krakowski, Julie Prin, Belinda, I can't say your last name, I'm so sorry, Angela Teague. They all completed their acute care.
Congratulations.
So I did want to take the time to shout them out. So
congrats, everybody.
Congrats. Awesome. All right, Abby, it's time. So the way we're going to set this up, I'm going to set up the timer. We're going to go for about a minute, and we're going to hit random questions, and you spit out the first thing that comes to your mind. You game?
I might say husbands again.
That's okay.
All right. Nicole, are you ready with the first question?
Sure.
All right, let's do it.
All right, Abby, if you had to sing one karaoke song, what would it be?
I don't remember. Jesus, I have no idea. Okay, I'm going to have to pass. I can't think of it. I have too many.
Okay, no problem.
Here's one. Give us another podcast that you would recommend for our listeners to listen to.
Morning Cup of Murder.
Link up a murder.
It's
Interesting.
It's this day in history of what happened in the past of like different unsolved mysteries.
Fantastic.
All right, what is the most random app on your phone?
Lingo.
What's your favorite way
Always
to decompress
learning.
after a long day of working in the hospital?
Going outside barefoot in my grass with my dogs. Very grounding.
Fantastic.
Would you rather give up coffee or social media?
Social media.
Oh, yeah.
What trash reality TV show are you watching nowadays?
Beyond the Villa. Love Island Beyond the Villa.
Would you rather plan a trip or be surprised by it?
Plan a trip.
Abby, name a game show that you watch and you're like, oh, I could totally win this.
Oh, we just watched it. The 1% Club on Hulu. It's new.
Fantastic. And that brings us to time. So, Nicole, if you want to ask the final question.
We have one more.
Oh, boy.
You know you're an acute care therapist when?
Your closet is primarily scrubs.
Yeah.
I know you can't see it right now, but I'm wearing scrub pants.
I was going to say, that or you prefer wearing scrubs over jeans, because that is me any day of the week.
That is true. There's some days I'm just like, just put these scrubs on. It's just easier to hang out. It's going to be an at-home type of weekend.
Yeah.
And my scrubs, like the brand that I wear, they are from a workout company too. So I'm like, oh, my joggers, I can go wear them to the gym instead of finding my leggings. So we're here.
And honestly, I just love the cargo packets. I put so much stuff I can.
Absolutely.
You got your 2 ASCOMs, your list,
Yes,
yep, exactly.
your belt,
pull socks, the pens.
pull socks.
Tape measure, reflex hammer, everything that I need. I'm good to go.
There you go. You're fine.
Awesome. Abby, thank you so much for spending the time with us on the podcast today.
Thank you guys so much for having me. I feel like this was like a long time coming.
That's it. Hopefully we'll have you again soon.
Yeah, absolutely.
Awesome.
We would like to thank Abby for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Arguelles and Nicole Neveau. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay. Sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for another engaging acute care conversation. Thank you for listening, and may your shoes and scrubs stay clean today.
And I'm Leo. In today's episode, our guest is our PTA member at large, Abby Catamas. We discuss how she became. Oh, I'm so sorry. All right.
Okay.
Do it again. We'll do it again. One more time.